Hello, my name is Sanjita Danuwar and this presentation is for SPE262 Assessment 3 Subtask 2 Verbal Defense. My allocated worksheet is from week 4 that focuses on dermatomes and muscle innervation. In this verbal defense, I will explain how dermatomes correspond to specific regions of skin supplied by sensory nerves and how motor innervation enables muscle movement. I will also describe how these systems are functionally connected in voluntary movement and discuss their clinical relevance in rehabilitation and injury assessment. A dermatome is an area of skin supplied by sensory fibers from a single spinal nerve root. Dermatomes are organized sequentially along the spinal cord, cervical, thoracic, lumbar, and sacral, and they help clinicians identify the level of spinal or nerve injury. For example, C2 supplies sensation to the back of the head and upper neck, C5 supplies the lateral shoulder region, T4 corresponds to the nipple line, T10 supplies the area around the umbilicus, L1 corresponds to the groin region, and similarly L5 supplies the big toe and dorsum of the foot, and S1 supplies the lateral aspect of the foot and heel. Dermatomes are clinically important because loss or alteration of sensation in specific skin zones can help identify which spinal nerve root is affected. For instance, numbness in the thumb might suggest injury to the C6 nerve root, while loss of sensation around the umbilicus indicates a lesion at T10. In cases such as spinal disc herniation, clinicians can perform a dermatome test using light touch or pinprick to assess which nerve root is compressed. This allows for targeted diagnosis and management, such as physiotherapy for nerve decompression or surgical referral if severe. Now let's move to the muscle innervation. Muscle innervation refers to the motor nerve that stimulates a specific muscle, allowing voluntary contraction. Each spinal segment gives rise to motor neurons that travel through peripheral nerves to activate muscles. The biceps brachii is innervated by the musculocutaneous nerve, enabling elbow flexion. The deltoid receives input from the axillary nerve and responsible for shoulder abduction. Similarly, the quadriceps femoris, innervated by the femoral nerve, extends the knee. The gastrocnemius is controlled by the tibial nerve, allowing plantar flexion. The trapezius is innervated by the spinal accessory nerve, cranial nerve 11, assisting in scapular elevation. The flexor carpi ulnaris is powered by the ulnar nerve for wrist flexion. The tibialis anterior receives input from the deep fibular peroneal nerve, which allows dorsiflexion of the ankle. When a voluntary movement is initiated, the motor cortex sends signals through upper motor neurons (UMNS) down to the spinal cord or brainstem. There, they synapse with lower motor neurons (LMNs), which exit the spinal cord via peripheral nerves and connect directly to the muscles. The release of acetylcholine at the neuromuscular junction triggers the muscle contraction. Understanding this muscle innervation is essential for assessing nerve injuries or motor weaknesses. For example, damage to the femoral nerve may cause weakness in knee extension, while tibial nerve injury affects plantar flexion during walking. This knowledge helps clinicians localize neurological deficits and plan targeted rehabilitation. The sensory dermatome and motor myotome systems work together to coordinate movement. Sensory input from dermatomes provides feedback to the brain about limb position and touch, allowing the motor system to adjust movement accuracy. For example, when walking, the L5 dermatome senses pressure under the big toe, while the tibial nerve activates the gastrocnemius for plantar flexion. This interaction ensures coordinated and stable movement. In summary, this verbal defense presented my understanding of dermatomes and muscle innervation. Dermatomes help localize sensory loss, while muscle innervation expands motor control. Together, they form the basis of functional anatomy and are critical in clinical settings such as rehabilitation, spinal injury assessment, and neurophysiological testing. Thank you for listening.